Zoonotic infections primarily affect animals, and humans become hosts on accident. Transmission is usually via direct contact with the animal in question. There are a lot of bugs listed here, and you can go through all of them in time, but I'm going to talk about the really high yield ones that are likely to show up on your boards. Bartonella is a gram-negative rod that is responsible for cat scratch fever. So, here's our kitty cat, Bart, and as the name suggests, cat scratch, Bartonella is transmitted to humans via the scratch or bite of a cat and causes chronic, painful lymphadenitis in lymph nodes near the site of infection. Low-grade fevers may also develop. You'll learn in cardiology that Bartonella can also cause bacillary angiomatosis, which is seen in AIDS patients or other immunocompromised hosts. As you might have guessed from the name, angiomatosis is when blood vessels proliferate and take on the appearance of tumor-like masses on the skin. Sometimes these masses appear like purplish nodules and can be confused with Kaposi sarcoma in AIDS. Biopsy is required to figure out which it is. Both Kaposi sarcoma and bacillary angiomatosis, seen here, have a purplish vascular hue. Pasteurella is a gram-negative coccoid rod that normally lives in the mouths of cats and dogs. It can cause localized wound infection, cellulitis, and lymphadenopathy following a bite from an infected animal. So, your patient gets bitten by little Rufus here, and you're the physician in the ED. Are you going to suture this up and send the patient home? No, closing these wounds can actually worsen the infection by trapping the bacteria in there. Yersinia pestis is an organism important for historical reasons. It caused the plague or Black Death, which wiped out population of Europe in the 1300s. It is carried by rodents and transmitted to humans via fleas. It can cause the bubonic plague, characterized by high fevers and buboes, which are erythematous, painful, swollen inguinal and axillary lymph nodes. You can see that here. Yersinia pestis can also cause pneumonic plague, which has respiratory and constitutional symptoms and an even higher mortality rate than bubonic plague. Regionally, you might see it in the southwestern U.S., and characteristically, the patient will be in severe septic shock or have severe pulmonary disease. Time for another flash quiz. Name the 3 spirochetes. And your answers are Borrelia, Leptospira, and Treponema. Remember, this is the BLT sandwich that you don't want to eat. Gardnerella vaginalis causes bacterial vaginosis, or BV, and it is not an STD. Okay, so you go to do an exam and you see some thin discharge on the cervix. Being the sharp young physician that you are, you take a sample for microscopy. You look under the scope, and what do you see? I'll give you a clue. The answer is clue cells. Great. Clue cells are vaginal epithelial cells that take on the stippled appearance that you see here. You can see this little stippling on the epithelial cells. They appear this way because there are so many bacteria adherent. Okay, let's say you're not convinced, or maybe your attending wants to get one more test to really be sure. This actually happens, by the way. What do you want to do now? The KOH whiff test. And what is the classic odor that you'll see described in the question? I hope you're saying fishy odor because you're right. And how do we treat this, doctors? Shall we give some antibiotics? Yes, let's prescribe a course of metronidazole. Do we treat the partner as well? No, remember that this is not a sexually transmitted infection. BV should be contrasted with Trichomonas vaginitis, which is an STD, and we'll discuss this infection later in the parasitology subsection. Next, we'll be talking about 2 tiny obligate intracellular organisms, Rickettsia and Chlamydia. They cannot live outside a cell because they don't make their own ATP. Let's start with Rickettsia species. Rickettsia and the related organism Ehrlichia have arthropod vectors such as ticks, mites, and lice. Coxiella used to be classified in the Rickettsia family, but it was reclassified. It is still included here because it's worth thinking about it with rickettsial diseases. It's transmitted by aerosol and causes pneumonia. Let us first talk about the most striking feature that helps us differentiate these various infections. Of course, I'm talking about the vasculitic skin rash that is associated with Rickettsia rickettsii and typhus. Contrast this with Ehrlichia, Anaplasma, and Coxiella burnetii, which are never associated with a rash. And what is the classic triad of Rickettsia, and typhus? The answer is headache, fever, and of course our vasculitic rash. Okay, what is the cause of this rash? Why do I say it's a vasculitis? Well, the petechial rash is actually due to replication of rickettsia within blood vessels. There's a great table in your first aid textbook that you should review as you get closer to your exam, but don't spend too much time trying to memorize each organism's vector. I'd say that's probably lower yield. Instead, focus on Rickettsia rickettsii, which causes Rocky Mountain spotted fever. As we just discussed, Rickettsia rickettsii is usually associated with a rash, and the rash of Rocky Mountain spotted fever is very unique. Do you remember how it is classically described? Well, it starts peripherally on the hands and feet and later moves in centrally to involve the trunk. In other words, it starts distally and moves proximally. Great. So, let's contrast this with Rickettsia prowazekii, which causes typhus. The rash for this infectious disease starts on the trunk and moves distally to the palms and soles. Rocky Mountain spotted fever is the second disease that affects the palms and soles. Do you remember the first one that we talked about? I'm thinking of a disease that has 3 stages. The disease is syphilis. And can you tell me which stage of syphilis was associated with the rash? That would be the second stage. Remember that the first stage is characterized by a painless chancre, and the third stage is associated with the neurological system, causing tabes dorsalis, and also the cardiovascular system, causing aortitis. Final syphilis recap question. What is special about the pupils of people with tertiary syphilis? Remember that they accommodate but don't react, and this is called the Argyll-Robertson pupil. Excellent review. So this whole palm rash sole thing turns out to be pretty unique. So much so that if you see it on a board question, you can narrow the answer down to just 4 diseases. I like the mnemonic CARS to help me remember that rashes on the palms and soles of the body could be caused by Coxsackie A virus, rickettsia, and syphilis. How are you going to remember that? Well, just remember that you drive cars with your palms and soles. And one final thought on these rashes. Can you tell me an inflammatory skin disorder that can also affect the palms and soles? I'm thinking of erythema multiforme, which is the 4th disorder that causes a rash on the hands and feet. And that pretty much rounds out the list of palm and sole rashes. Okay, doctors, we've made our diagnosis of Rocky Mountain spotted fever. How do you want to treat it? What antibiotics should we use? For intracellular organisms such as rickettsia and chlamydia, doxycycline is highly effective antibiotic because it is one of the very few drugs that can penetrate the cells where the bacteria are living. Flash quiz. A 45-year-old international businessman presents to his primary care physician. His skin exam is pertinent for red maculopapular lesions on the palms of his hands. On further questioning, he states that about 6 weeks ago he developed a painless ulcer at the base of his penis that disappeared on its own. What is the most likely diagnosis? And how do you treat this patient? So our patient has classic symptoms of secondary syphilis, which is caused by the spirochete Treponema pallidum. He has a palm sole rash and a history of a recently healed painless chancre. Treatment is with penicillin G. The chlamydia family are a quite often tested family of bugs, not only because of their overwhelming clinical relevance, but also because of their unique microbiological features. Chlamydia are obligate intracellular organisms and have a unique replication cycle. Let's start with our basic human cell here, with the nucleus in blue. In fact, let's say that our cell has already been infected with chlamydia. This little guy is called a reticulobody, and he is the replicative form of chlamydia. Reticulate bodies are the metabolically active form which can amplify DNA, RNA, and protein production using host cell ATP. They actually divide by fission, so you can see that they are multiplying here. So we have the replicative form called reticulate bodies, right there. And what about the infectious form? What do we call this? The infectious forms are called elementary bodies, seen here. These little spore-like particles can exist outside cells and are protected from the elements by their cross-linked peptidoglycan exterior. They get extruded from the cell and are taken up by endocytosis. These elementary bodies are often known as infectious bodies, elementary infectious bodies. Once in the new cell, they essentially germinate to form new reticulate bodies, and the cycle continues. Once there are enough reticulate bodies to sustain production, intracellular elementary bodies are made that can be extruded from the host cell, starting the cycle all over again. So, which form would you see in a cytoplasmic inclusions in tissue culture cells infected with a sample from the patient? The correct answer is reticulate bodies. So what's the most important chlamydia subtype that we must know? Chlamydia trachomatis. It is a sexually transmitted bacteria, and we will dedicate an entire slide to it next. Types A, B, and C are associated with follicular conjunctivitis, especially in Africa. These chronic infections can cause blindness. You can remember this one with the ABC mnemonic: Africa, blindness, and chronic. Types D through K are definitely the highest yield of the chlamydia serotypes for your exam. These are the buggers that cause the chlamydial infections you've heard of: urethritis, cervicitis, prostatitis, and of course the feared complication of pelvic inflammatory disease. Let's talk about everyone's favorite topic for a second: babies. Can you think of 2 infections that might occur in a neonate exposed to chlamydia? When a baby passes through an infected birth canal, they will be exposed to whatever bacteria are living in there. If it's chlamydia, then the 2 infections are neonatal pneumonia and neonatal conjunctivitis. And what is the classic description of the cough in a baby with chlamydial pneumonia? A staccato cough. Okay, great. But how about if there is GBS, or group B strep, in the birth canal? What do they get then? Meningitis, sepsis, and pneumonia. And can you remember the bacteria that tends to cause co-infections with chlamydia? It is also a cause of PID. The answer is Neisseria gonorrhea. So what is our treatment then? Ceftriaxone and doxycycline. Remember, ceftriaxone plus doxy. The ceftriaxone is for the gonorrhea and the doxy is for the chlamydia. And then of course you'll need to treat the partner as well and see the patient back in clinic to test them for a cure. Lastly, serotypes L1 through L3 cause lymphogranuloma venereum, or LGV, which presents with small, painless ulcers on the genitals. Hey, wait a second. Do you remember the other sexually transmitted infection that presents with painless ulcers? Well, it's kind of an ulcer, but I'm thinking of syphilis. How about painful ulcers? There's 2 answers here. Remember, Haemophilus ducreyi causes painful ulcers, and the other one is herpes simplex virus, which causes painful vesicles that then erupt and form painful ulcers. LGV progresses from small painless ulcers to painfully enlarged inguinal nodes. Okay, last flash quiz of the day. Name 3 infectious causes of a palm sole rash. Remember, this is a very specific type of rash. And our answers are Coxsackie, which you'll discuss in the virology section, rickettsia, and syphilis. And the final bacteria we will discuss as a part of this lecture. Can you remember what is unique about Mycoplasma? Well, mycoplasma doesn't have a cell wall, and so it can't be gram-stained. And they're also the only bacteria whose cell membrane contains cholesterol. Mycoplasma pneumonia causes an atypical pneumonia. Do you remember the signs and symptoms of classic versus atypical pneumonia? Let's attack this problem this way. Time for some pulmonary integration. Here are two chest x-rays of patients with pneumonia. One of them is a 63-year-old female who presents with fever, chills, and cough productive of blood-tinged sputum. Which x-ray is consistent with this patient's presentation? The x-ray on the left shows a right lower lobar consolidation. This is consistent with the presentation I've described for you. So, what is the presentation of the patient on the right? Usually, symptoms aren't as severe as classic pneumonia. Patients will complain of a nagging, dry cough and generalized malaise. Note the diffuse nature of the pulmonary infiltrates in atypical pneumonia. There's no clear area of consolidation. It's just kind of haziness all over. Mycoplasma can cause the body to make high amounts of IgM antibodies, which target the red blood cells due to antigenic similarity between cell membranes of the bacteria and the red blood cell membrane. Hey, do you remember what class of antibodies form warm agglutinins? That's IgG antibodies. IgG form warm agglutinins. You'll learn more about cold and warm agglutinins in the hematology section of the course, but for now I want you to remember that mycoplasma causes cold agglutinins. So, why don't typical antibiotics like penicillins work against mycoplasma? Well, I just told you that mycoplasma lacks a cell wall. And how do penicillin class of antibiotics work? They inhibit cell wall synthesis, so we can't use any of those drugs. So what's our drug of choice? The answer, azithromycin. Azithro is very commonly used, or you could also use erythromycin. Okay, that concludes our lecture on clinical microbiology.